So we're going to go through reproductive health, and I'm actually going to go through the whole lecture as if we were in class, but I will divide it up into chapters so you're able to go back and forth between the lecture and the module. So the objectives today are to review the anatomy and physiology related to reproductive health, describe how racism and intergenerational trauma contribute to poor health outcomes related to maternal and infant mortality, and identify strategies to promote birth equity and reproductive justice. So I will have another lecture on the reproductive justice part. In terms of the racism, I think that you all are pretty aware of the inequities between Black mothers and white mothers in the United States. And so I will have a separate slides to go over that issue if you're unfamiliar with it. But in class, you all seem like you were pretty familiar with it. So we'll jump to the why. And so as we go through this, we're going to kind of follow the timeline between like conception and pregnancy and labor and delivery, and then the postpartum period, which is really actually very dangerous. And as we go through this, think of how stress impacts any of this. Think of how stress impacts the cardiovascular system, because so much of pregnancy and development prenatally has to do with the cardiovascular system because we're reliant on the placenta, right? And so, and remember all of those different changes that take place during pregnancy that we talked about whenever we were talking about the cardiovascular system, that will all come back into play. So just keep that in mind as we go forward. Reproductive justice. So I'll introduce this concept right now. The definition is the human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. So to actually have reproductive justice, this requires quite a bit. And we'll jump into the physiology of pregnancy. So fertilization. So to achieve fertilization, a single sperm must reach the oocyte within a window of about 12 to 24 hours from the time of ovulation. So it's a very narrow window. Sperm maintain fertility capacity for about 72 hours or 3 days. And then, so successful fertilization is often the result of intercourse occurring in the 2 to 3 days before ovulation. And the combined sperm and egg is called a zygote, and that divides pretty quickly until it becomes a ball of cells known as a blastocyst. And then molar pregnancies can arise because of an imbalance in genetic material in the pregnancy. And this happens about 1 in 1,000 cases. And some of the types increase the risk for cancer. So what does this look like? This would look like, instead of the genetic material of the oocyte and the sperm combining, maybe there were 2 sperms, or maybe there were even 3 sperms and no genetic material from the oocyte. And so these grow very quickly. And the way that we catch these is because mom's uterus grows and expands beyond what we would normally expect it to expand. And so it happens very quickly. And so here is, the progression of everything. The zygote is the initial, fertilized egg, and then you have an embryo, blastocyst. So another thing that can happen around this time, very early on in pregnancy, is that you can have a twin pregnancy. So, we're not necessarily talking about the twin pregnancy that is a result of 2 eggs, 2 oocytes getting released, because that's just like a sibling pregnancy. A twin pregnancy that is like an identical pregnancy happens because very early on that ball of cells divides. And so if you have it divide between days 1 and day 3, it actually might be pretty difficult to tell that it's an identical twin pregnancy. And that is another reason why some of that some of the issues that we talked about during the post-genomics talk about why identical twins and all those twin studies weren't as valid as we thought, because some of the identical twins were actually not, or some of the fraternal twins were actually identical twins. So that even that, skews some of that genetic research. But anyways, going back, this is actually good if it cleaves early on, because you have less issues. But then if it cleaves a little bit later on, you might have two twins sharing the same placenta. And then of course, if it cleaves too late, then you have the conjoined twins. But there's an issue whenever twins are sharing the same placenta, because they don't always get the same amount of nutrients. And you can tell this one is either a fraternal twin or it was cleaved very early on, because here's a placenta, and they each have their different placentas. But in the case where they both are sharing the same placenta, then you can have twin-twin transfusion. And that is where one baby basically gets starved and the other one gets way too much blood flow. And it, I think you would naturally think that the bigger one is going to be healthy, but they're both really unhealthy, because this little one's heart gets overwhelmed by the amount of blood rushing through its body. And so they're both very unhealthy, and they oftentimes have to go through surgical procedures in utero to stop this. The other risk of twin pregnancies, and this is whether they're identical twins or fraternal twins, is really towards the mom, because you have a whole lot more, especially if you have two placentas, you have a whole lot more fluid in your body, you have a whole lot more hormones in your body, you have a lot higher chance of having diabetes. So the placenta itself gives off hormones that actually increase your insulin resistance. And that actually makes a lot of sense if you are thinking of adaptations, right? Because you want the mom to have some insulin resistance, so there's extra glucose flowing in the bloodstream, so it gets to the baby, right? Well, when you have too many placentas, then you get kind of that, the adaptation gets pushed to a maladaptive mechanism. And so you do get a higher chance of diabetes. You get a higher chance of something called preeclampsia, which we'll talk about later on. And then 20% of triplet pregnancies will result in the delivery of at least one child with a major life long-term disability. And so the higher order multiples, which are triplets and beyond, place a significant risk for both mom and the babies. And so you want to have one at a time is really optimal. And we have to talk about this more and more because of IVF and all of the fertility, mechanisms or medicines. And so here's just what you would expect for implantation. So again, about day 3 after ovulation, day 2 or day 3, this is when fertilization occurs. And so, and then the cells divide, and then they have to implant in a certain location. Now, something can go wrong during this period too, which is an ectopic pregnancy. And so say the sperm were just little quick swimmers and they, fertilize the egg too early, then they can actually get implanted in the tube, in the fallopian tube. And that can be a life-threatening situation. And so, especially if it ruptures. And so this is one of the reasons why if, you're a young woman and you go to the emergency room with abdominal pain, why they have to give you a pregnancy test, just because they want to make sure that it's not an ectopic pregnancy. One of the risk factors for getting an ectopic pregnancy is actually a history of STDs. And PID is something called pelvic inflammatory disease, and that results usually from STDs. But what happens is, you might have heard that most people who have an STD don't have any symptoms, which is pretty true. But the thing is, that doesn't mean that it's not hurting anyone. So that chlamydia or gonorrhea, which are the two, very, very common STDs. What can happen is, even though you're not having any external symptoms, internally, it's going up the uterus, up to the tube, and it's making a whole lot of inflammation in the tube, and you can get scarring from that. And that can result in some infertility, because then you have issues, getting the egg where it needs to go, but it also can result in this ectopic pregnancy. And so the treatment for this is basically a medical or surgical removal. And surgery, laparoscopic, means that they're not splitting you open and just like opening your whole cavity, right? They're like sticking little cameras in, and it's a much safer process, a much quicker time to heal. And also, hopefully they want to spare your tubes, but we do have some disparity here. So Black and Hispanic women are less likely to receive surgery that spares the fallopian tube. So they're much less likely to spare, to get their reproductive capacity like spared. And yes, you can still get pregnant with just one tube, but it's not ideal, right? And then they're also less likely to receive laparoscopic, which is like the minimally invasive surgery. So much higher risk of having some of the complications. The physiology of a normal pregnancy. We'll go through some of this. The amniotic fluid helps to protect the baby from trauma and bacterial infection. It also facilitates growth and movement. So if you don't have enough, then you can have issues with the development of the fetus or embryo. And then it also helps develop the GI and respiratory tract. And so the baby kind of breathes in this amniotic fluid. Placenta. So the placenta is a really, really important organ, and we're just learning stuff about it, fairly recently. So this helps separate the maternal and fetal blood flow, although now we know that there's some mixing. This is where the exchange of gas and nutrients and waste and electrolytes occur. And this is also where the production of essential pregnancy hormones takes place. So this is really, really important. And so let's go through some of this hormone regulation, because it's very closely tied to the stress response system. So you have a placenta that secretes CRH. And remember, CRH is from, whenever we were thinking of like your HPA axis, we have CRH coming from your hypothalamus. But your placenta actually secretes CRH too. And that CRH helps the fetal adrenal glands secrete what they need to secrete. And for a little while, it actually helps them secrete androgens, so like testosterone and related hormones. And then the placenta actually helps turn the androgens into estriol, which it helps the mom's breast develop. And it also helps the blood flow be shunted to the uterus, and it helps that uterine growth be stimulated. So there's a whole nother, endocrine system going on with the placenta and the fetus and the mother. And so how does stress play a role? Well, through a lot of different mechanisms, and this is actually in your module, so I'll let you just review it there. And then this is also in your modules. But I want to skip to the placental insufficiency. So what happens if this doesn't go right? So you don't have a placenta the entire time. This actually happens after implantation. And part of that implantation is really, the opening up of these uterine vessels. And so you can see that this is like from the baby implanting into the mom's uterus. And so the baby's like cells goes over here and kind of opens this up. And this opens up that blood flow and allows for a more adequate exchange of nutrients. And so what happens if this doesn't work the right way? Well, then you don't have as good blood flow. You can just imagine what happens, right? Like you have a tiny little baby because you didn't get this huge like valley, you got this little thing. And let's see, let me. Experiment. So this experiment is actually, they're injecting nicotine into the ear of a rabbit. And so you can see what happens to the blood flow of the bunny's ear. And we'll kind of skip ahead because it's not looking great. But this is what the effects of nicotine are on blood vessels. And yes, this is a rabbit's ear, but the same thing happens in the placenta. And so when we talk about the risk of smoking, like it's pretty significant because you can see, well, you can see how they kind of just disappear. And that's what happens. And so one of the questions that I had whenever I was a medical student was like, well, how do you tell people, how do you counsel them against smoking during pregnancy? Especially because at that time, there were news reports coming out of the UK that teenage girls were smoking because they wanted to have smaller babies, because that's what we would say. You have a risk of having a smaller baby. But, and that just sounds kind of cute, right? But if you can imagine, you know, that nicotine basically makes the blood vessels go like that, then you can also imagine that it's also strangling the baby because it's just cutting off all that blood supply. And that's probably a better way to counsel, and it's more accurate. And so placental abruption happens. So this could happen with nicotine, this could happen with cocaine, it can also happen with accidents, but it's basically when the placenta rips away from the uterine wall and you might have a lot of bleeding right there. So the mom will get both sick, but then the baby also doesn't get the nutrients that it needs. You can also have a disorder of placental position, and that is when the placenta gets inserted into the wrong place. And so one of the risk factors for this is a C-section. And so every C-section you have a higher risk of rupturing during pregnancy. And yes, that means like the baby would just be like floating around in the abdominal cavity. But you also have another risk of, you know, a subsequent pregnancy having an abnormal placental position. And so if you have placenta accreta, which is over here, basically it invades the muscle wall of the uterus. So it's not supposed to go that deep. It's only supposed to be like the inner lining, but this one goes like way deeper than it should. And so if you can imagine it separating during pregnancy, which it can't, like you're basically like ripping your muscle apart, and that can't happen. And so they have to have a C-section for that, which again will leave them at a higher risk of developing this again. But actually for this, I think they have to do a hysterectomy when it gets to the placenta accreta, because you can't just take that one out. The placenta previa is just the abnormal position, but it doesn't go too deep into the muscle. And so, you know, the placenta is actually supposed to be up here, nicely tucked away. And you can imagine if it gets inserted down here, what might happen during delivery, that baby cannot escape, right? Because you need that placenta to still be attached to deliver oxygen and nutrients while the baby's being delivered. And if we just like bust through it, that's not going to happen. And so you can have a lot of like just hemorrhage that might also result in a hysterectomy, but you'll have to definitely have a C-section for this one. And this one shows, here's the baby, here's the placenta. This baby is not going to be able to get out. So I will stop right there and make a new video for the next section.